Il tema del webinar di oggi è la chirurgia toracica. Mi permetto però di, dopo averlo condiviso con gli altri, di togliere un pochettino di spazio alla professoressa Pedoto, perché per noi, forse un pochettino anche per lei, è successo qualcosa di importante che vogliamo condividere un po' con tutti i nostri specializzandi che sono collegati. Lunedì scorso è morto il professor Luciano Gattinoni, che per noi è stato una persona molto importante, sicuramente uno scienziato, un amante della musica e dell'arte. E quelli che l'hanno conosciuto sicuramente se lo ricordano. Era nato nel gennaio del 45 a Milano, si era specializzato in anestesia e rianimazione, e la sua esperienza è cominciata al Policlinico di Milano, e dopo un po' si è recato negli Stati Uniti. Allora questa è una frase che io cito spesso agli specializzandi della nostra scuola, che un popolo che non ha memoria è un popolo che non ha storia. Allora il compito mio di oggi è quello di cercare di fissare nella memoria di tutti noi alcuni elementi fondamentali, alcuni passaggi fondamentali. Questa era una diapositiva che avevamo fatto in occasione della celebrazione dei 70 anni del professor Kolobov. Kolobov è stata la persona dove il professor Luciano Gattinoni è andato, a Bethesda, e dove ci sono stati anche Warren Zeppel e Antonio Pesenti, e poi tanti altri dopo di loro. Quindi quello che potremmo definire un po' il padrino di tutto è questa persona, che è morta nel 2018, mi sembra, ed era Theodor Kolbov, una persona molto curiosa, e la persona che per primo aveva utilizzato il polmone artificiale a membrana. E i primi anni avevo lavorato con lui Warren Zeppel, che poi sarebbe diventato il capo dell'anestesia e rianimazione del Massachusetts General Hospital di Harvard, di Boston e Harvard, con il quale aveva cominciato a utilizzare il polmone a membrana come placenta artificiale. Teneva l'animale all'interno di un substrato liquido collegato con l'arteria e la vena ombelicale al polmone artificiale. In questa maniera il feto di animale sopravviveva. Dopo di lui a Bethesda c'è andato questo signore, il professor Luciano Gattinoni, il quale aveva questo motto, e queste sono le sue parole che ha detto al webinar che ha fatto un mese e mezzo fa con le nostre scuole: conoscenza e pazienza, passione e cervello, e soprattutto curiosità, guardare la realtà con gli occhi di un bambino. Allora io adesso cerco di illustrare a tutti voi qual è stata in uno dei campi in cui Luciano si è applicato, come ha applicato questa massima. Questi erano i polmoni dei pazienti che arrivavano, erano in terapia intensiva dopo un po' di tempo che venivano trattati. E come diceva Luciano, allora bisogna osservare il problema, capire qual è il problema. Lui ha guardato questo, ha visto un po' di questi malati e ha cominciato a pensare se questi polmoni potevano essere in qualche maniera gestiti in maniera alternativa. E qui ha osservato in questo lavoro, che è uno dei primissimi lavori che ha fatto a Bethesda, come attraverso l'utilizzo di un circuito extracorporeo poteva essere rimossa la CO2 prodotta dall'animale e quindi non era più necessario ventilare l'animale per farlo sopravvivere. Allora ha fatto questo lavoro sperimentale nell'animale dove veniva utilizzata una pressione positiva a bassa frequenza e veniva rimossa la CO2 dal polmone artificiale. E aveva anche visto che se il polmone non veniva sostenuto con un'adeguata pressione, diventava sempre più piccolo e perdeva in FRC. Era curioso, guardava quello che succedeva e alla fine ha ipotizzato che si potesse applicare questa tecnica anche ai pazienti con insufficienza respiratoria acuta. E il suo, questa è una sua diapositiva, la sua genialità, una delle sue genialità, è stata proprio quella di dividere la funzione polmonare in rimozione della CO2, una domanda che ci faceva quando eravamo specializzandi, studenti, perché respiriamo noi? Respiriamo per ossigenare, no, respiriamo per rimuovere la CO2, perché noi basterebbero 2 atti ventilatori al minuto per ossigenare tutto il sangue. Dobbiamo respirare 12 atti, 15 atti per rimuovere la CO2 e lui ha avuto questa intuizione. E con solo 5 pazienti è riuscito a fare questa pubblicazione su Lancet, e se guardate bene è il 1980. E nel 1980, nella conclusione, dice che questa tecnica sembra prevenire il trauma, il barotrauma polmonare e i danni che possono conseguire, extrapolmonari, che possono conseguire la ventilazione meccanica. Ci abbiamo messo poi 45 anni per poi consolidare, un po' meno, il low tidal volume ventilation e le tecniche per evitare il volo barotrauma. Era curioso, ha osservato questo e il tutto nella nostra memoria è partito da questo gruppo che era il gruppo di medici e di infermieri dell'Emma Becla, del Policlinico di Milano, con i 2 scienziati che mancavano in quella fotografia, che poi si è sempre più ingrandito. Questa è una foto fatta quando ha compiuto 70 anni Kolobov, e poi ho voluto aggiungerci delle altre figure, ne mancano tantissime altre che ci starebbero proprio bene in questa fotografia, perché sono tutti componenti della scuola che Luciano ha fatto partire. E voglio chiudere con questa foto. Eravamo a San Diego, Luciano è stato premiato in quella sede perché la Society of Critical Care Medicine ha riconosciuto in lui una figura veramente importante. Penso fosse il primo europeo ad essere premiato, ed eravamo sulla terrazza davanti alla sede congressuale. Mi piace finire così. Grazie Luciano. Thomas.
Grazie. Vai Luca, grazie.
Grazie, buongiorno a tutti, grazie Roberto, che ovviamente per tutti noi, Roberto a caduta è stato un po' il... Quando sono arrivato come studente, Roberto era lo studente anziano appena assunto, quindi per me è una sorta di caduta, ma io ho fatto oltre 40 anni a lavorare con Luciano, quindi come ha detto giustamente Roberto, sono giorni difficili per noi a ripensare a tutto questo bel passato. Nello stesso tempo, però, è stato bello tutto quello che abbiamo, tutto quello che ci ha lasciato e anche oggi, come dire, un'occasione perché l'introduzione alla relatrice di oggi è un po' collegarsi con la storia perché e credo che sia una bellissima esperienza proprio in questo contesto perché Alessia quando io l'ho conosciuta sono ancora un po' più anziano ed era arrivata come specializzanda e allora lavoravamo io, Paolo Pelosi, Luciano, si lavorava alla meccanica respiratoria, si lavorava a una serie di progetti e in questo filone era stata proposta ad Alessia una borsa di studio per andare negli Stati Uniti a perfezionare delle tecniche con l'idea che poi tornasse, mettesse, che riportasse questa esperienza, perfezionassimo le cose, eccetera. Come spesso succede, ovviamente la ragazza aveva delle capacità, la ragazza ha trovato la sua strada e quindi è tornata da questa esperienza americana sostanzialmente dicendo bello, ma io torno a vivere là e lasciando dietro di sé un po' di, diciamo, arrabbiatura perché ci si era persi questa occasione per tanti anni, come dice Alessia, tutti avevano questo, Alessia ci ha mollato, ma nello stesso tempo la gioia, come dire, riconosce che una persona con dei meriti aveva, grazie a questo percorso, aveva trovato una strada che l'ha portata ad essere una persona di riferimento nell'ambito della chirurgia toracica e quindi per noi è diventata a questo punto il relatore che avremmo voluto avere nei nostri seminari a parlare di chirurgia toracica. E l'abbiamo coinvolta anche nell'ambito dello smart proprio perché è una persona di riferimento nel suo settore e ci sembra, come dire, il cappello conclusivo perfetto di questa introduzione che ha fatto Roberto, pensare che una, una studentessa in Luciano, grazie al suo progetto, alle sue ideazioni, alla sua volontà, le ha fatto fare una meravigliosa carriera e questa carriera oggi torna a beneficio di tutti gli studenti e che credo che possano usarla anche come modello per dire se uno ci mette energia, capacità e ha voglia, si trovano delle bellissime strade per maturare. Quindi io rinnovo il mio ringraziamento a Alessia, i miei complimenti per tutto quello che ha fatto in questi anni. Adesso credo che sia giusto il momento di darle la parola e lasciarle al seminario. Grazie a tutti per questo spazio e buon lavoro Alessia e complimenti ancora.
Beh, grazie per l'introduzione e grazie per l'invito. E mentre tiro le diapositive, voglio giusto aggiungere, allora vediamo, 3 secondi, il mio ringraziamento nei confronti del professore e di Paolo e di Luca. Io ero una specializzanda nel 96 al VECLA, per cui me lo ricordo benissimo, le diapositive dei polmoni, i pazienti che abbiamo portato dalla terapia intensiva al CT scan per fare le immagini, era un'avventura. E il fatto che il professore non mi ha parlato per anni e anni e poi quando lui è andato a Göttingen praticamente direi che ha ricominciato a rivivere quello che tutti i suoi studenti hanno fatto, quelli che non sono poi più tornati, per cui molte grazie dal profondo del mio cuore al VECLA e a tutti quanti per l'opportunità che mi è stata data. Allora, come si dice qui, without further ado, questo è il titolo della presentazione che Luca mi ha spedito con l'intero gruppo e l'abbiamo intitolata Thoracic Anesthesia Unveiled, Best Practice and Innovation. E come Luca ha detto, io sono venuta negli Stati Uniti, ho rifatto la specialità e da 20 anni a questa parte lavoro al Memorial Sloan Kettering, che è un centro tumori. Ho anche un appuntamento accademico con la Cornell, per cui qui sono le mie disclosure, e questo è il mio email nel caso in cui vogliate contattarmi. Io ho provato e controprovato a cercare di fare questa lezione in italiano e ho fallito miseramente perché purtroppo dopo 30 anni che sono qui non riesco più a parlare in italiano dal punto di vista scientifico e quindi abbiamo deciso con mio sommo dispiacere di fare lezione in inglese. Le domande, come è stato detto, vengono messe nella chat. Possiamo farle ibride e possiamo cambiare avanti e indietro la lingua, per cui facciamo un minestrone visto che siamo vicini a Natale. Con questo inizio. Allora, I have nothing to disclose financially. I will be mentioning products and tubes because we're talking about thoracic anesthesia, but I have nothing that involves money. So this is my disclosure. And because this is a very, very broad topic, I decided to narrow it in terms of like giving you some pointers on how to build a plan when you are booked to do a thoracic case and see what you have to keep in mind to provide a safe anesthetic that hopefully have the best outcome possible. So despite being in 2024 with all the innovation for surgery and anesthesia, we still have complications when it comes to thoracic surgery. And we have cardiac complication. The most common, as you all know, is atrial fibrillation. And we have respiratory complication. The most common is pneumonia. And so you may wonder why. I mean, we have all these guidelines, and this is a very famous one. You all know because since 2019, we have been bombarded with IRA's guidelines, and this is specific for thoracic surgery. And it's a long list of, recommendations based on evidence for the whole perioperative period with the goal of using a multimodal approach so to decrease complications. Now, despite the guidelines, complications are still there. And this is a more recent, it came out in 2021, is a study where they looked at 40 cases open versus thoracoscopy. And as you see, the pulmonary complications are less if you look at atelectasis and pleural effusion, but they're not zero. So there's still some work that needs to be done. Now, if you are training now, I think that your practice is mostly this on the right side of the screen. You go to the OR on a daily basis, you do thoracoscopy, you do robotic cases. If you are as old as me or older, you remember the thoracotomies. And so the anesthetic had changed to customize it to the new technology. Just to give an idea, if you're not doing robotic cases, those are coming in your theater. This is like 10 years of numbers at my institution. These are all robotic cases. As you can see, it's kind of like an uptake. And when you look at specifically robotic thoracic cases, it's parallels the numbers of total cases. We have the dent in 2020 because of COVID, but the numbers are going up. And you may think, okay, this is just a technique that we use for younger people. It's not the case. I split our numbers based on age, and I divided less than 70, because in my head, less than 70, you are a young patient. 70 to 80 is kind of like getting into the old age, and then over 80 is elderly. And as you can see, you have an increase in numbers over the past 10 years of the three population. And these are thoracic cases, segment, lobes, wedges, esophagectomy, and mediastinal mass resection. So they're fairly major cases. So when you think about your population, it's mostly made of elderly people. So they come with their own issues when you build your anesthetic. So the goal of this hour, I just want to lead you through the preoperative period. And so there's a lot of talk about frailty assessment and how to optimize and prehabilitate patient to decrease post-op complication. I want to spend a few words about immunotherapy because this is the phase of the new preparation. instead of using chemotherapy, patients are exposed to these drugs and they have significant side effects. I'll just spend a few words about the logistics when you're doing robotic cases, and then a few words about monitoring, and then spend some time on fluids, the ventilation, and analgesia, specifically tailored for thoracic surgery. So for the preoperative period, I think that it's pretty obvious that the goal is to assess the risk, modify, and ideally optimize it. And this is what we do at our institution. When we have elderly people, we send them to the consultant. This is a study that was done by the geriatrician. They give patients an electronic questionnaire that investigates 9 topics. And based on what scores in need to an improvement, they tailor the consult and the rehabilitation specifically to that area that needs help. So you can see they do functional status, cognition, social support is very important. Once you discharge patient, if they don't have social support, they're not going to do very well. There's a lot of literature coming out on emotional health being as important as physical health. And what they did recently, they looked at their data and they looked at the need, like how much time these patients have to, or like they need to fill up the questionnaire. Usually, as you can see, the median is like 10-15 minutes. And if they need any help. And so if patients can fill the questionnaire quickly and by themselves, they're good. If they take time and they need help, this raises some flags. If they cannot fill the questionnaire, they're classified as frail in addition to failing the other status component. And when you read all the literature, and a lot of it is coming from Europe, everything stresses the importance of time. So you need to identify the problem so that you can have enough time to fix it. And the magic number usually is 4 to 6 weeks. Now, this is easier said than done because at least here in the United States, for some of the cases, the patients are seen within 1 week or a few days prior to coming to the OR. And so sometimes you may not have enough time. Everybody is in agreement that supervised activity is better than if you give homework to patients to do it on their own. And as said, mental health is as important as physical activity. Now, I like to quote this paper. It was published in 2019 because it's focused specifically on thoracic surgery, and it's coming from the Swiss group. They go over what you need to do for rehabilitation in terms of like exercise status, and not only exercise, but also pulmonary assessment and respiratory muscle rehabilitation. They agreed that if you don't have 4 to 6 weeks, 1 week is good. And you should mix ideally aerobic resistance and respiratory muscle training. They point out the importance of nutrition. If someone scores malnourished, they should be referred to dietitians so that they can have a customized program. And there's more and more about immunonutrition just to build muscle mass in addition to exercise. If you exercise and you are not eating well, you are basically going to the opposite of what you're trying to get. You have muscle wasting instead of building up muscle mass. And we all know our fasting guidelines with the ERAS protocols have changed. And then there's some thinking about the cessation program, and we're gonna go over more with the smoking, but also with the vaping, which is becoming more and more popular, and what they're vaping. Not only tobacco, marijuana is becoming something that patients are doing more often and they are admitting. So this is to show you what we did during COVID at our institution for rehabilitation. We put together online program that was supervised by a respiratory therapist, and they recruited patients undergoing anatomical lung resection or esophagectomy at least 1 week of exercise prior to surgery, and they were scheduled to have 2 sessions per week, again supervised. And on the right side here, this is the list of what this program was, which is fairly common. They do like a 5 minutes warm up and meditation, and then you have your warm up, you have your muscle training, and then the cool down, and then some end meditation like shavasana if you're doing yoga. And people really liked it. Not only there was a high satisfaction, and people would recommend this program to anybody undergoing the same procedure, but they thought that it was very helpful with anxiety and stress, fatigue, pain. And so it's something fairly easy, if you will, to put together. However, it requires funding. And one of the main problems of all this program is the lack of funding in pretty much every institution. This is another study that stresses the importance of exercise before surgery. Now, I think that it's a bit of a skewed study. It came out this year from China. They took patients who were fairly young, like 56 median. My clientele is 80 and older. And they all were undergoing a minimal invasive thoracic cases, and everybody was instructed to do 150 minutes per week of moderate activity and then 75 minutes of vigorous activity. So the control was kind of exercising, if you will. The study group, they were put on a cycloergometer, and for every 2 days, for 16 days, they were exercised at high intensity. They underwent surgery, and then they looked at outcome, and they saw that patients who underwent the exercise pre-op had less complications. They had better vital signs. They have less signs of inflammation in terms of fever and neutrophils. And in spot checks, like 5 patients per group, they looked at mRNA for tumor necrosis factor, so more signs of inflammation, and the exercise group was doing better. So if you have time, I think that the take-home message for this study is that it's doable. However, you need to have time. And again, these are very young patients who follow instructions. So for smoking, I think that we all remember smoking in the old days, like tobacco. Nowadays, vaping is becoming more common, and vaping is a problem more in the adolescents. Vaping is used as a means to quit smoking, and there's some data where it's not a foolproof method to quit smoking, because people then get addicted to vaping, and so you're back to square one. Now, this is what we ask patients at our institution. We start with the tobacco, but then we start investigating any other form of tobacco intake and marijuana as well. So I just want to spend a few words about marijuana because it's becoming more popular. This is the heat map in the United States. As you can see, in the United States, except for 6 states, marijuana is legal, both for recreational and medical use. And in Europe is coming. So I put the arrow in Italy. So in Italy, if you are caught with marijuana for recreational use, they give a penalty without incarceration, while it's legal for medical use. So the problem of marijuana, it's all based on dose. This is like a table that I built just to have an idea of what is low, medium, and high. And it's in milligram of the active component, the tetrahydrocannabinol, by weight. And so this just gives you an idea of what we're talking about. Now, the higher you use, the more catecholamine release you have. And that's the problem with the side effects of the cannabis. This was an exercise because when you ask patients, do you use marijuana? And then how do you use it and how often? Depending on how you use it, you may have different side effects. And so smoking has a faster onset and a shorter duration. Eating has a longer onset and a longer duration. When people eat marijuana, they don't feel the effect, and so they keep eating and eating until they are intoxicated. And so I thought it was interesting, if you put 500 milligrams of marijuana in a cartridge and you vape it, every puff is like 4 milligrams, for example. If you put it in a bong, it's 30 milligrams. And so that's the point of asking how you're doing it. And this is like a table in terms of the effects of the oral ingestion of marijuana, with a little table of what happens. The higher is the dose, the more side effects you have, and they're all related to catecholamine release. These guidelines came out in 2021 because in the United States, this is becoming such a huge, I wouldn't say problem, but consumption, that the American Society of Regional Anesthesia put their minds together and came up with some guidelines to guide the anesthesiologist in the intraoperative period on what to do with these patients. And they asked 9 questions and they gave the answers. So the first one is, should all the patients coming to the OR and using cannabinoids be screened? And the answer is yes. So not only you need to ask them if they're using it, but you need to ask how much, how they're using it, and when was the last dose. Is there evidence that you should stop or continue the cannabinoids or postpone elective cases? And so the consensus is that if you're using cannabinoids, you should stop them 72 hours prior to the operation. If you're coming to the OR intoxicated, like for any other drugs, you should cancel the case. But I thought it was interesting that if you smoke marijuana 2 or 3 hours prior to surgery, their recommendation is to postpone surgery because their concern is the high catecholamine tone that you may have, and so the increased risk of having a myocardial ischemia or a cerebrovascular accident. Now, what is the recommendation in patients who use cannabis and also do use opioids? And this one, there are really no recommendation. It's like a conversation with the pain service and coming up with a common, consensus. I'm not gonna say anything about the pregnancy because this is focused on thoracic. Should we change the intraoperative doses of our drugs in patients who use marijuana, and what do we need to do for the ventilator? So think about if people are smoking cannabis, they are gonna have potentially COPD. And so the vent setting should be set up accordingly. They may have abnormal PFTs, high dose because of the increasing catecholamine. They may increase postoperative nausea and vomiting. They may cause hypothermia and shivering because it affects the hypothalamus, and marijuana affects platelet function, so they may be coagulopathic. Should we need to be concerned for anything in the postoperative period? And yes, it's anything that is related to a high catecholamine state. So cardiovascular complications, strokes, cardiomyopathy, the shivering, they may be hyperalgesic. So trying to find the best analgesic plan is maybe a bit challenging. And then are there any special consideration between opioid and chronic opioid user and cannabis? This is something for the pain service, so these patients should be going for a consult. And what do we do for the cannabis withdrawal symptoms? So there's a cannabis withdrawal syndrome that can present 24 to 72 hours from abrupt cessation if you smoke or ingest high dose. It peaks at 1 week and it starts subsiding within 2 weeks. And the definition of heavy use is more than 1.5 gram per day of smoking and more than 20 milligram per day PO consumption. Now, one thing I want to mention is that usually people who use cannabis also use or may use other substances that may affect the anesthetic. And so when you take the history, you should investigate for anything else that they may be doing. Now, for pre-op medications, there's a lot of word about precision oncology. And I think that it's not just in the United States, it's also in Europe. And the whole field of personalized medicine, where basically patients are treated as a single entity. So especially for cancer, the goal is to find the right treatment for the right patient given at the right time and dose. And this was a little graph that came out on the New York Times when they wrote an article on precision oncology. But I think that it expresses very well this like cycle. You may have like a suspicion of cancer, you come for a biopsy, the specimen goes to the lab. And nowadays, more and more hospitals have genotype banks. At our institution, everybody goes for what is called impact. And so their specimen goes to the lab and it gets analyzed for genomes. And they get genomic mapping so that they can be matched to a specific drug that is tested in vitro and then it's given in vivo. Those patients are monitored and followed periodically. And so this is how the face of, adjunct treatment changed over the past, 20, 40, 50 years, if not more. So back in the days, patients would get chemotherapy, and chemotherapies are drugs that kill cells. Nowadays, as you can see here in the past 20 years, it's a combination of, yes, chemotherapy, but also a lot of targeted therapy, which inhibits tumor growth and immunotherapy, which potentiates the immune response. And once you start combining, you have all these effects acting on the cancer, but also on the patient. So the problem of all these drugs are the side effects. And you may say, I'm not an oncologist, so I'm not going to give these drugs. But I think that you really need to be aware of the side effects, because some patients may come not optimized to the operating room. And the three most common drugs that are nowadays used are the checkpoint inhibitors, the CAR T cells, and there's a lot of work being done on vaccines, but we're not there yet. So I'm not going to spend any time other than mentioning that they're working on cancer vaccines, including mesothelioma. The checkpoint inhibitors are antibodies that are built to target specific receptor on the tumor cell to break their killing capability against the T cells, and for the T cells to enhance their killing ability. And so the goal is for the T cell to kill the tumor cell and preventing the tumor to increase the apoptosis. So for lung and esophageal, these are the two main antibodies that are used. Anything that ends with a MAB should raise some flags. And the problem, as said, are the side effects. And the most common one are the endocrinopathies. All these patients, or the majority of them, are going to develop thyroid dysfunction. And the most common one is hypothyroidism. They may have pretty much severe thyroid suppression. So these patients need to go to an endocrinologist and being optimized prior to elective cases. Usually the treatment is often irreversible, and it's basically hormonal replacement that may be long life lasting. They may have pancreatitis, so they may come with uncontrolled diabetes. They may have hepatitis. Remember, all our drugs are eliminated by the liver. And they may have adrenal insufficiency, which I think that if you don't think about it, you may miss it. So if you have hemodynamic instability in someone who have been exposed to immunotherapy, think about stress dose steroids. For the lung, this was one of my patients. I had to do wedge resection. She had melanoma and was treated with immunotherapy. This is a fairly severe pneumonitis. They require a prolonged course of steroids, and they may be at risk for opportunistic infection. So you should check their x-ray, and these patients usually come with PFTs. And then finally, they can have cardiac toxicity. The most frightening is conduction abnormalities. Those people can have locks, and they may have cardiac arrest. They can also have heart failure and low ejection fraction. Obviously, that goes with the heart failure. So you need to kind of like dive deeply in the pre-op evaluation to find out if you have any of this. For the CAR T cells, they have even more severe complication. Those are chimeric antigen recombinant. So they harvest T cells, they engineer in the lab, they make them to target specific tumor, and then they re-inject it in the patient. Those treatments are approved for blood tumors and for melanoma. You are mostly exposed to ICU, so you all know cytokine release syndrome. These are patients who come to the intensive care unit. It comes in different grades, and the one with grade 4 are on, the vent and with pressors and fairly severe support. They require high dose steroids. Other complication that is fairly common are neurological events. Now, we have investigated the pre-op. We have done, we have done all this, paperwork. Now we have a plan. Patient is optimized, comes to the OR. What do we need to look for to prevent complications? So in the United States, positional neuropathy is #1 cause of lawsuit. I think that it's kind of like a worldwide issue. So you really need to make sure that these patients are positioned properly, especially when they have robotic surgery. They are placed in very unnatural position. And so one thing that may be problematic is the neck. So they can wake up with neck pain, but also the shoulder. So you really need to make sure that nothing is compressed, but also the robotic arms do not lean on the shoulder. There have been case report of direct compression, but also burns because of the camera. Like the old models, the camera ports would get hot. And if they're in reverse Trendelenburg, you want to make sure that they're secured so that the patient doesn't slide on the floor. And the heels are very well padded. Otherwise, by the end of the surgery, you may have like pressure sores. Now, for specific issues for the robot, I think that hypotension is one of the main problems. And you see it a lot if you're doing robotic esophagectomy. So the most common robotic case is Ivor Lewis. So as you know, you start in the abdomen with the dissection, and then you resect and reconstruct in the chest. So you have two parts. During the laparoscopy, the hypotension is mainly related to the pneumoperitoneum, and then the fact that these patients are put in reverse Trendelenburg. And then towards the end of the resection, they may injure the left diaphragm, so you may have a left pneumothorax. So if you have stable vital signs and then you have hypotension, just ask the surgeon if they injured the diaphragm, and if the hypotension is long-lasting and severe, they have to, decompress that chest. Well, when you go in the thoracic part, a lot of surgeons like to insufflate to decrease, to expedite the collapse of the lung. And so you may have a tension pneumothorax. So that can give you hypotension for that. And so the goal is to try to maintain, obviously, your vital signs stable with fluids and pressors. Pressors were considered like bad, but now there's a lot of, change in terms of like how we feel and how the literature is proving that they're not as bad as they thought. This is just to grab your attention. It was like a drawing that I did for my resident about what happens during esophagectomy and the blood pressure. So when the patient comes in, is hypertensive, you induce an anesthetic, it becomes hypotensive. Then you do laryngoscopy, the blood pressure goes back up. Then we wait for the surgeon to scrub and come in. So you have a relative time of hypotension. They make incision, the blood pressure goes up. Then they put the patient in reverse Trendelenburg and they insufflate, so the blood pressure goes down. And then eventually you catch your breath. Everything is stable until they go and work under that left diaphragm. So when you have your left tension pneumothorax, the blood pressure goes back down. Now, usually this is towards the end of the case. Either they decompress or they desufflate, they put the feeding tube, and then you go on the side. And again, you start all over again. The blood pressure goes down. You wait for the surgeon. They make incision, goes up. They insufflate the chest, it goes down, and then eventually this is finished and the patient goes to PACU, hopefully normotensive, but most of the time slightly hypotensive or maybe hypertensive. Usually the abdominal part is 3 to 5 hours and the chest part is 1.5 to 3 hours. And why are we paranoid about this blood pressure? Because we've been brainwashed about anastomotic leak. And the reasoning is that the stomach is perfused by 5 arteries. 4 of them are sacrificed during this procedure, leaving you with only 1. If you're interested on the topic, this is a very good review article that came out from my institution in 2023. This is the QR code. You can read on it, and it goes over how the anesthetic has changed in the past 20 years. One of the papers that is mentioned is this one. I really like it because it's done by surgeons. It's 45 patients, open esophagectomy, all Ivor Lewis. They all have an epidural that is placed pre-op. A group, the black group, the primary activation, they start the epidural prior to surgery. They use some phenylephrine to maintain the hemodynamic. The late activation, they wait to start the epidural until the end. And they looked at the perfusion of the antrum and the corpus with this microcirculation, the laser speckle contrast. And as you can see, there's no difference between perfusion between the two groups. So the epidural that is usually blamed for hypotension is not really making a difference. And the fact that they're using phenylephrine also is not killing anything. But I think that the interesting part of this study is this one on the corpus. You have a decrease in perfusion that it's similar between the two groups, and it gets better once they make the anastomosis. And so their conclusion is that once you revascularize the conduit, at that point you have more blood flowing there and the anastomosis is happier. So the issue of the blood pressure is an issue that it's an issue in every case that you do, not specifically just in esophagectomy. And back in the days when I started my training 20 years ago, we used to give a lot of fluids because, you couldn't vasoconstrict. And this is an old paper, but it's very popular. This is, it's quoted very much. where they looked at fluid resuscitation. They took the median amount of fluid. It was kind of 11 cc per kilo per hour. Whoever had more were the liberal, whoever get less was the restrictive. And they were looking at anastomotic leak and ileus, which they didn't find. But the patients who had the high volume of IV fluids had more ARDS and more mortality. And so going with fluids may not be a good way to go. And this is a nice review article where they're thinking, so if you want to guide your fluid management with a goal-directed method, can we apply what's written in the literature to thoracic surgery? And I think we can, but with some grain of salt. First of all, there's not really a very good definition of what is a liberal approach, a restrictive approach, or a moderate. So if you're looking in the literature trying to get a number, like a recipe, how much fluid should I give? You're not going to find it. Then a lot of the data is retrospective, and so it may be a bit biased. A lot of the data is done in abdominal cases, and so definitely the abdomen is not the chest. And they all talk about, the challenge. And what are we challenging, though? Because thoracic cases are not bloody cases. I mean, you lose 200, 300 cc of blood loss over like 5-hour surgery. Most of our cases are vasodilated. And then the next question is, how are we going to do it? For the pulse wave analysis, you need a closed chest. And for thoracic cases, the chest is not. For the thermodilution, you need invasive monitors, which are not placing anymore. And if you're doing anything in terms of esophageal, if you're doing an esophagectomy, you're not going to have an esophagus. And with the hilar manipulation, any probe that you put in tends to move. And so you keep having to readjust. And so it's a constant exercise. However, the conclusion of this paper is that you can use those devices and follow trends, and that can help you to, decides when you may need volume versus pressors and timing it. And then you put all your information together and you use your judgment, which is basically the recommendation for everything that we do in life. Pressors, they had a bad rap, but now it's getting better. Now, I know that in Europe, you use norepinephrine more than phenylephrine. In the United States, we use phenylephrine. I like this study because it wouldn't fly in the United States. It was done in Belgium. They took 24 healthy patients. They put an arterial line, a central line, a PA catheter, and they induced an anesthetic for a laparoscopic sigmoidectomy. So it's a minor procedure. And they looked at the blood pressure. If they had a decrease in mean arterial pressure, more than 80% from baseline for more than 3 minutes, they would give a bolus of phenylephrine. And as you can see, the phenylephrine increases the blood pressure, but it also increased the cardiac output. And their thought is that because of the venoconstriction, you have an increase in your stroke volume. And so phenylephrine is not such a bad drug. And we did a QI project at our institution because we were having this debate with the thoracic surgeon about the anastomotic leak. We just looked at open cases. We had a percentage of like 16% that back in the day was consistent with the literature, and we couldn't find any correlation between pressors and anastomotic leak. The only thing that correlated was BMI. This is a study that I just found about norepinephrine. One of our excuses not to use it was because you need a central line. Now, maybe it was the reasoning 20, 30 years ago, but not anymore. You can give norepinephrine in a peripheral vein. And this study demonstrated that not only you can do that, the amount of extravasation or complication is very low. And even if norepinephrine extravasates, the complication associated with it is very minor. But that saves patients from a central line, and central line gets infected. And so I think that that's one of the major key points. For minimally invasive thymectomies, the only thing I want you to make sure once you do these cases is that, again, the patient is properly positioned, because now we're not on a lateral decubitus, we're on a sloppy lateral. So this shoulder, usually it's against one of the ports, the arms. And if the arms keeps hitting it, you can have a brachial plexus injury. Also, if this arm is too bent in the back, if you put yourself with it, you can feel the brachial plexus being stretched. And so pay like 5 minutes of, checkup before they put the drapes up. You need lung isolation. So whatever is the device of choice, just make sure that you can provide good lungs collapse and you can access that. And for intraoperative events are the same as if you were doing a thymectomy open. With the potential of arrhythmias, you can have the potential of hypotension, nerve injury. So you need to discuss with the surgeon if there's any nerve entrapment in the mass, and that is going to affect your paralysis or lack of thereof. Keep in mind that you can have vascular injury, and so where you want to put your access. I personally like for good luck measurement to have access on the feet, just because even if you may not have SVC compression from the mass, sometimes they may clamp the SVC, and so you lose access if all your money is on the upper extremity. And then the space that they're accessing is very small, and so you can have a contralateral pneumothorax, so be vigilant. This is a paper that I want to mention on this topic because it is a landmark in the literature of mediastinal masses. So if you have done a PubMed up to 2022, the majority of the information was either a case series or a case report. This is the first, scientific study where they took adults with large mediastinal masses and they did staged induction of general anesthesia. They did a fiber optic intubation under sedation. They put the fiber optic at the point of narrowest diameter of the trachea, and then they staged the induction with spontaneous ventilation in general, and then they did positive pressure with general, and then they paralyzed. And this is like the average of all these 17 patients. But if this is your baseline and this airway collapse and this is airway dilatation, you see that the airway gets bigger as you induce and you paralyze. Now, this is at the beginning, the patient is semi-sitting. They're adults and it's before incision. And so they didn't continue the study once, they flattened the patient and they start the case, but none of them had to have a rigid bronch or go on ECMO as a rescue. And there's a follow-up study ongoing, so more to be published in the future. And this is another very good paper that is in press, so which I think it should be in your reference armamentarium. And it goes over rational approach on how to stage the risks for patients with mediastinal masses and what to do in terms of your induction, but also your, strategic plan in case you decompensate. And so what are the intervention other than just changing position? So what are you going to do with the airway? What are you going to do with the circulation, and how you're going to put them together? So with this is for the OR procedure. However, we are more and more involved in out of the OR. And I think that I'm not sure if you do interventional pulmonology or if you are starting to provide anesthesia to the interventional pulmonologist, but many more staging is done by them rather than the OR. The cervical mediastinoscopy or anterior mediastinoscopy that we used to do back in the past now have been replaced by robotic bronchoscopy and endobronchial ultrasound biopsies. With the robotic bronchoscopy, biopsy in the periphery, and the advantage compared to going to interventional radiology is that you can do bilateral biopsy in one session, and with the EBUS, doing the staging of the lymph nodes. And more these people are using cryobiopsy to have larger specimens, and so these cases may be bloody. And so the point I want to make with this is you need to be vigilant and have everything that you need available. So when you are doing these cases, the name of the game is providing good lung expansion so that they can get to the lesion and biopsy the tumor rather than landing in vessels. So these patients go the day before to have a high intensity, high definition CT scan. They map the trajectory, and then they come to the operating room and undergo a general anesthetic. At least at our institution, we do it under GA. Now, there have been case reports of places where they do these cases with sedation, but it's not ideal, I think, for the proceduralist, the anesthesiologist, and the patients. Those patients need to be very still with the lung hyperinflated. So we put an 8.5 endotracheal tube. We use positive pressure ventilation. For the anesthetic, a lot of people do IV anesthesia. I think that in Europe, you do mostly TIVA since you have proper device to dispense the anesthetic. Here, we do a combination. We do dexamethasone for bronchodilation and airway edema. Those cases are not painful, but if the provider requires or thinks that patients require analgesia, we use IV acetaminophen, and at the end we give nebulizers. And this is the setup. It's usually in a very small room with a lot of equipment, and we are usually kind of here in the back. The vent settings, they have been like a work in progress, but we started with very high tidal volume, which was kind of like a different concept since we have been brainwashed to use protective lung ventilation. And now they tell us, you know, you have to use 10 cc or 12 cc per kilo ideal body weight. After the paper that I'm gonna show you, we kind of changed to 6 to 8, which is a little more, you know, human. We use high PEEP, 8 to 10, and the lowest FiO2 with the goal of prevent atelectasis. These patients are paralyzed, so they don't cough and move. And when they do the spins for the CT scan, we do breath hold with APL at 20 to 40 centimeter of water. As you can imagine, the issue is hypotension. At this point, there's a conversation, and we kind of find a setting that it's a compromise between the pulmonologist's request and the patient's hemodynamics. The chance of pneumothorax and bleeding is very low, as well as hypoxemia and aspiration. And this is the paper that have changed the management of these cases. It's a trial that came out from MD Anderson, where they compare their control cases. Back in the days, they used to use a supraglottic device, and with tidal volumes to 6 to 8 cc per kilo, ideal body weight, high FiO2, no PEEP, and no recruitment. And their protocol was with an endotracheal tube, like similar to what I show you. So 6 to 8 cc per kilo ideal body weight with 50% FiO2, PEEP 8 of 10, and recruitment. And they saw that the amount of atelectasis immediately after induction and at 40 minutes were much less in the VESPA group. And so this is the recommendation for most of these cases in the United States. These procedures are getting more and more creative, trying to find optimal conditions. And so we have done some of these cases in the lateral decubitus after this paper came out. And some proceduralists are suggesting to put the patient prone so that the lesion can get closer to the chest wall, and so it's easier, since Gattinoni has taught everybody that ventilation and perfusion change with changes in position. It's easier said than done, because when you're trying to change position with the pulmonologist, it's basically an exercise of acrobatics. It takes forever, and it's not as flawless as it happens in the operating room. And also keep in mind that once you have to do the second part with the endobronchial ultrasound, you have to put them supine as well. More and more papers are coming out on cryobiopsy. So if it's not appeared in your operating room, it will very soon, just because with cryobiopsy, you can have a bigger, larger specimen. Problem of this is that they bleed. And so when you see yourself booked to do cases with the interventional pulmonologist and you're using cryobiopsy, you really need to discuss, one, how they're gonna do these biopsies. Most of them are done with flexible bronch, but some of them are done with the rigid. And so if you're doing rigid bronchoscopy, you need to have all your equipment in the room, including the jet ventilator. If they're doing through the flexible bronch, you put an endotracheal tube, and our secret weapon to decrease hemorrhage is to put a bronchial blocker at the area where they're gonna take biopsy. And this is the protocol. They put the blocker at the site of contact, and then they take the specimen, they inflate the blocker, and they wait. The blocker goes outside the endotracheal tube, which is another exercise. And I put here an image to compare the scopes. This is what we use in the OR to check the double lumen tube. This is the therapeutic bronch that they need to put in case they run into bleeding. And so if you have an endotracheal tube, even like an 8.5, and you have a blocker in, you don't have enough room to put the therapeutic bronch. And so you need to put the blocker outside. And I don't know if this video is gonna work, but I wanted to show you what a painful exercise is to put the blocker before you have the endotracheal tube. And we use this device because it's not as expensive. It's very flimsy. So despite the fact that you put a band, it doesn't want to go in. And so the way that I made it go is to put my finger against the blade of the video laryngoscope so that I'm pushing the blocker through the cords. And so I kind of gave you the idea. And so it's easier to do this in an elective situation than trying to do it in an emergency. Monitors, we all use standard monitors. I just wanted to ask you, do you still use arterial line for your thoracic cases? Because a lot of practices are removing the use of A-line. We do because we are in a teaching institution. We don't put central lines anymore unless patients have poor access. There's more and more use of the ultrasound, and you European have taught us the multiple uses. And this was my little question to just pick the interest of the audience. There are a lot of non-invasive options that can be used. This is what we have at our institution. They did a study looking at this device versus the arterial line, and there's a good correlation with the mean and the diastolic, but not that well on the systolic. For the lung isolation, you have double lumen tube and blockers. You can be a proponent of one or the other depending on your preference. I think that in any training, you should become familiar in using blockers, even if you hate them, just because you may have that patient that requires lung isolation and it's a difficult airway. And so I got burned in the past few times, especially when I was a very young attending, since surgeons don't really like blockers. And so I wanted to provide lung isolation with a double lumen tube. I had a secured airway. I tried to use a tube exchanger. I lost the airway, and then it turned into like a nightmare trying to resecure it again. And so blockers maybe are not the greatest, but they work. Just keep in mind that they always go in the surgical side, and so they can get stapled in. And so before they clamp or they staple anything that has to do with the airway, you need to either withdraw it or remind the surgeon that there's a foreign body. But they have the advantage, especially if you're leaving patient intubated, you don't have to exchange the double lumen tube at the end. Now, technically, you can say, we're all anesthesiologists, we can leave the double lumen tube and we can manage it in the ICU. However, it's a lot of resistance to work. So when you start weaning someone from the vent, you need to keep that in mind. And it also, the double lumen tube does not fit a therapeutic bronch. And so if you want to do toileting, you really have to change it. So I'll leave this as some food for thought. Now, there are several brands of double lumen tube. I just wanted to mention this one just because it's a fun gadget. We don't buy them anymore because they're too expensive. And I personally liked the single lumen tube because you could look at the blocker. And this is when we bought them, just because we used to move the bed. And so trying to get to the double lumen tube and try to position it was complicated and required a lot of flexibility. But that's something that you can use in terms of, for the device. This was a sleeve resection. The surgeon was about to cut into the airway, so we could see real time what she was doing, and then we saw the quality of the stenosis. I mean the anastomosis. For the ultrasound, you can use the ultrasound to check the double lumen tube if you don't have the fiber optic. You can use the ultrasound in the recovery room if you have someone desaturating. It has very good sensitivity and specificity to check pneumothorax and atelectasis and pleural effusion. And so it has multiple purposes. Now, for the ventilation, I think that I feel kind of embarrassed to talk about ventilation to this audience because, you're all disciples of Luciano Gattinoni and a lot of big names. And thankfully to all these big names, I think that the concept of protective lung ventilation has finally arrived to the operating room. And we went from highly recommending it to using it. This is a landmark paper that you all know about mechanical ventilation and lung injury in the ARDS patients from Slasky and then Ranieri. That's when, the concept of volotrauma, barotrauma, atelectasis, and high FiO2 were introduced as causes of inflammatory response in the alveolus. And so local damage and systemic damage. And Professor Luciano Gattinoni wrote even an editorial meditating back in 2018, which one was worse. But more and more is coming out on ergotrauma. I see Francesca on the call, Luciano and all this group in Göttingen have worked a lot on that. And again, that work has translated to the operating room as well. So what you're doing in the ICU is coming to us. And back in the days, I was wondering, is what happens in the ICU applicable to the operating room? In the OR, we ventilate patients for like what, 3-5 hours. It's rare that we go for more than 8, okay, 12 at the most. It's not like days or weeks like it happens to the ICU. And yes, there's more and more literature coming out that is proving that there's lung injury related to mechanical ventilation during lung surgery. And you have 2 insults. So on the dependent lung, that is what we ventilate, is the setting of the vent, but also the stress on the capillary. So it affects both ventilation and perfusion in terms of giving damage. Obviously, on the lung that is operated, you have the surgeon that is causing mechanical damage. And then when you re-expand, you have the way you re-expand with the volume or the pressure, and then the oxygen. And there's more and more literature coming out on how deleterious is to use high FiO2 on once you re-expand, just because you have an ischemic organ with a lot of inflammation where you're putting basically fuel on the fire. So all this causes an increase in pro-inflammatory cytokines, so biotrauma, and this can cause local damage and systemic damage. So in April, I had the pleasure of introducing Luciano for this session on mechanical ventilation. And I really liked what he said to open it. And his 3 questions were, what is protective lung ventilation? How are we doing it? And who are we protecting the lung from? And his answer was, we're protecting the lungs from the physician. It's the doctor that is killing the lung, which, you know, it's a smart way to put this in 3 questions. So when you think about the operating room, there have been at least 20 years of search for this holy grail of what's causing lung injury. And this is a paper that just came out a few months ago in anesthesiology. And when I saw this, I thought, that's why we cannot find what's causing lung damage, because it's too many things all together. And so I think we're getting there, but we're not there yet. So way back in the days, just because we said that il popolo che non ha memoria è un popolo che non ha storia, we started like this, ventilating people. So when I was a resident in the 90s, I was told when you do thoracic, you use 10 cc per kilo ideal total body weight, not ideal. You put the respiratory rate so that the end tidal is in the 40s. You use 100% FiO2, and you do not use any PEEP. And the reasoning was that in the 90s, the fiber optic scope was not in every single operating room. And so it was very hard to figure out where these tubes were. And it's proven that this causes injury. This is a model in the pig where they looked at the lung that is ventilated, the lung that is collapsed. Here, the ventilated, the collapse. This is the histological damage. And you have all sorts of cytokines. And when you look at the oxidative stress, you have damage on the lung that is ventilated, the lung that is collapsed. You have damage in the circulation. The longer is the case, the higher is the injury. And the more you take out, the more you have injury. And so this is something that gave some food for thought. And this was the first paper that came out that suggested using low tidal volumes. It was published in 2022. It's a meta-analysis. And they looked at 8 versus 6. And the main concern when this whole exercise started was that we would cause hypoxemia because those patients were being atelectasic, and now we're ventilating with less tidal volume. But there was no hypoxemia, there was no difference in compliance, and there was no difference in length of stay, but they saw a difference in pulmonary complications. So that's their message. You should use lower tidal volume. So the same group looked at the role of PEEP, and obviously PEEP after recruitment is beneficial. And so the concept of using protective lung ventilation was introduced and stressed with the ERAS recommendation. And this is what we do in the operating room in 2023, 2024. We start with low tidal volume. We try to put individualized PEEP. We do recruitment maneuvers. And does this work? So this is a study where they looked at almost 3,000 patients through the MPOG database. And they looked at two years, 2012 and 2016. And found out that anesthesiologists were using lower tidal volume, but this was not making a difference in pulmonary complication. And so probably the tidal volume, as we saw from the spoiler alert, is not the only component. And these are 2 papers that came out this year where they looked at variable tidal volumes, which is something that you use in the ICU, with the thought that since we don't breathe with the same tidal volume, if we change it during the period of one lung ventilation, we should have better oxygenation and less pulmonary complication. And they did not find, they didn't find either. and I had the pleasure of writing an editorial about this. So we're still looking for this needle in the haystack. So the next thought was maybe we just use driving pressure. And I like this paper because it puts in a visual what is the problem of using ideal body weight and tidal volume. You can have two people with the same ideal body weight, but different total lung capacity. And so if you use the same tidal volume, you may be on two different parts of your pressure volume curve. The same group did prospective randomized, trying to see if driving pressure and, individualized PEEP were making a difference in post-op complication. And again, they did not find any difference. And so that's where the thought of, mechanical power comes into play. And this is a very famous paper. It has been presented in many, many meetings. But this is what you introduced in the ICU, and this is what we translated it into the operating room. So they did a sub-analysis on the paper of the driving pressure, and they calculated mechanical power and mechanical energy. And look at this. So the longer the surgery and the higher the mechanical power and the mechanical energy, the more postoperative complication you have. So there is a signal here that needs to be investigated. I don't think that we are at the point where you can give recommendation for clinical practice, because I did the exercise of calculating mechanical power during a case that I did myself. And after a while, I had to give up because I couldn't keep up doing the calculation, adjusting the vent, and paying attention to what the surgeon was doing. So I think that this is where AI is going to help us out. And if you think that oxygenation, I just have to mention it, is benign, this is a paper where they looked at high FiO2 and high, they defined it as 60%. It's not beneficial, especially if you use high FiO2 for re-expanding the lung. I like this paper because this is practical. So it came out this year. It's the end of the iProv one lung ventilation multi-center randomized case. And they did open lung approach during one lung ventilation, and those people found a decrease in postoperative complications. So this is something that we can do in the operating room. We start with the regular 8 cc per kilo ideal body weight with the PEEP, and then once we go on one lung, for the recruitment group, it was a fairly cumbersome recruitment process that lasted 45 minutes. So hopefully we can find a way to make it shorter, because at least the surgeons in this country are not going to wait all this time. But there's some good information on this. And this is continued in the postoperative period, which I think that it's something that sometimes we forget. The operation doesn't end in the operating room. So these patients were tested, put on room air. If they desaturated, they were put on high flow nasal cannula, and desaturation was sat less than 92%, otherwise on face mask, compared to just like the standard group. And this study is on, it's done recruiting, but we're waiting for the final, information. And so finally, to put this marathon home, I just want to spend a few words on analgesia before we leave it open for questions. The question of using multimodal is something that it's common. Anytime you do some regional technique, you really need to discuss it with the patient, and that's why you need to have a good plan at the beginning of the case so that you can have a discussion. And this is the same picture that I showed. So since surgery has changed to minimal invasive, regional anesthesia has evolved. We're putting less and less epidural, which is a shame, because as anything technical, you become better at doing it with the more you do. And we do more and more blocks, and we do our blocks at the end of the case. Once the case is done, the patient is already prepped and draped for us. We do either serratus anterior plane block or any block in the back, to be consistent with the ERAS guidelines. And so we applied regional, we do multimodal with acetaminophen and non-steroidal. We usually do ketamine for chronic pain patients, and we use dexmedetomidine as an adjuvant, and dexamethasone for postoperative nausea and vomiting, but is also a weak analgesic. If you want to know more about it, this is a nice article that is coming. It came out as one of 4 parts where it goes over the multimodal analgesia option for thoracic surgery. And this is a table that I did taking information from that paper. So when you have your option, you have regional and intravenous. For the regional, you have neuraxial and peripheral neuroblocks. Intravenous, we do opioids and adjuvants. The opioids are basically backup. For adjuvants, we use the one time, and we use infusions. and this is the cocktail for our cases. So usually it's a regional with a peripheral nerve block and adjuvants with the one-time and the infusions with opioids as a rescue. We used to use gabapentin and pregabalin, but after this review article came out, we stopped just because it didn't show any effect on preventing chronic pain, but it also had a lot of side effects in terms of hypotension and visual changes, especially once you start mixing these drugs with what we use commonly for anesthesia. And in terms of analgesia, there was no clinically significant difference between the control and the study group. You have options for the peripheral nerve blocks. So we said your neural axial and your peripheral nerve blocks. Depending on where the incision, you should pick the right block. Our surgeons like to do intercostal nerve blocks. I'm not a fan because when you do them from the inside, and the definition is not that great, but they inject and a lot of the anesthetic comes out from the site. I don't know if it shows, but she's injecting here and you have local coming out here. So what we usually do is serratus anterior plane block, and we just published a study where we did a prospective randomized comparing the serratus with placebo. We did deep injection in minimally invasive segment and lobes, and we saw kind of like a small difference at 10 hours in the presence of multimodal. These are cumulative data in terms of morphine equivalent requirements at rest and with pain. And so there's more that needs to be done. The numbers were what they were. We had some deviation from the protocol, but that's something to keep in mind. And this is a block that I really like because it's a peripheral nerve block that is really close to do a paravertebral block, but is not. So it qualifies as a peripheral rather than a neuraxial. And it's called midpoint transverse to process pleural block. So you scan the patient as you would do a paravertebral and you put your local anesthetic here. We published a case report where we were doing this for thoracoscopy, and we do our thoracoscopy and talk pleurodesis under sedation with this block. So the patient comes in the OR, we mark the area where the pulmonologist is gonna make the incision, and then we inject in the area local anesthetic. And as you can see, spreads up and down 3 levels. And this is the patient sedated with just some propofol while they are taking chunks of pleura. She was the perfect candidate, didn't move. And so it's something to keep in mind. And with all the blocks, there's a lot of excitement. And are we really jumping on this train too fast? Every month there's a new block. There's not a lot of like prospective randomized, even though they are coming out in terms of study. And so both epidurals and paravertebral blocks, so neuraxial and peripheral blocks, have pros and cons. And I think that we should keep in mind both. So for the local anesthetic in the United States, people use a lot of liposomal bupivacaine with the claim that is long lasting. The problem is that is expensive. This is a paper that came out where they compare both liposomal versus bupivacaine hydrochloride, and they didn't see any statistical significant difference, so we stopped using it at our institution. There's some literature coming out on cryo neurolysis. We used to do them when I was a fellow. They stopped, not because of the acute, like this is a very small study where they showed that the morphine equivalent requirement was very low intra-op and post-op. The problem is the post-op, once the nerve regenerate, these patients can have chronic pain. And I didn't see any information on this study in terms of follow-up and the incidence of postoperative chronic pain. As anything with the opioids, the pendulum keeps shifting. We went from pain as the 5th vital signs to not using any more opioids. This was a study where they looked at comparing dexmedetomidine with narcotics. So it was remifentanil versus dexmedetomidine, and they had to stop it prematurely because of bradycardia and cardiac arrest. So I think that, like anything, finding a common ground, like a middle, would be useful. And I think that we're going to the middle with the precision medicine, because more and more tumors are being tested genetically, and there is a signal that based on the, on the genome of the tumor, people may respond differently to narcotic. This is a study that came from our institution. It's retrospective. They took 750 patients undergoing minimally invasive lobectomy, and they looked at, cancer recurrence at 5 years based on the anesthetic. They looked at no adjunct, dexmedetomidine, and ketamine. And if you look at this, it looks like the more narcotics you get, the worse survival you have. However, when they looked at the genotype, they saw that you can have protective genotype and not so protective. So if you have Wnt or Hippo, the more narcotic you get, the better you do. Well, if you have these two, the more narcotic, the worse. And so I think that moving towards the future, genetic analysis is not going to be just used for the chemotherapy, but also for anesthesia, and not just for the pain medications. This is what I did for, I kind of changed this for the analgesia, but this is something that we debated and wrote. It came out in April this year, so if you're interested in the topic, this is the QR code. And there's more and more written about the whole anesthetic host. As you know, it's not only the local anesthetic, but there's also studies comparing IV anesthesia with volatile opioids, local anesthetic per se, the non-steroidal, and some of them have positive effects, some of them have negative effects. And so I think that we are at the point where we need to think about the oncologist and customize. And so with this, I want to conclude. And the conclusion is that anesthesia is evolving at a very fast pace, and it's trying to keep up with the evolution of surgery. In addition to this, we are dealing also with sicker patients. And so when we plan the anesthetic, we really need to keep that into account. And it seems that with all the genetic and the way we're evolving, we can contribute to decreasing complications, and not just, things on a daily basis with the positional neuropathy, the fluid management, obviously the lung ventilation and analgesia. And so it's just a question of keeping our mind open and keep learning despite, finishing residency and training. And I think that with this, I'm going to conclude my marathon. I'm going to stop sharing, and I think we can leave it open to questions. And hopefully you're still awake.
Thank you, Alessia, for your excellent presentation. It's very interesting for all of us. We have several questions from the chat. The first one is basically the anesthesiologist now plays a key role in the risk stratification. So how do you manage a patient with marginal cardiovascular reserve? I'm talking about severe aortic stenosis, mitral regurgitation, or severe coronary artery disease. What is your opinion about that?
So, do you want to do the questions in Italian or in English first?
As you like. Come preferisci, guarda.
Allora, direi che la domanda è interessante perché dipende dal tipo di intervento, giusto? Se tu vieni per fare un intervento elettivo dove hai tempo a sufficienza per ottimizzare alla T tutti i vari problemi, per cui hai la stenosi dell'aorta, la ripari, hai l'insufficienza valvolare, la ripari, hai un positive stress test, vai a mettere gli stents. Il problema, almeno per quanto riguarda il cancro, è che la maggior parte delle volte la frase principale è che non c'è tempo, perché se devi essere anticoagulato per 6 mesi o un anno, potresti perdere la possibilità di avere un intervento curativo e entrare nella fase della palliazione. E quindi nel nostro ospedale c'è sempre questa cosa del decidere i rischi verso i benefici, e facciamo un sacco di interventi con pazienti che non sono super ottimizzati. Li mandiamo, cioè nella maggior parte dei casi facciamo intervento medico, per cui quello di sicuro, anche se in realtà richiede un esercizio per la gente per ricordarsi di prendere i farmaci, piuttosto che per quanto riguarda fare esercizio. Per cui it's a really tough decision when to cancel and when to go ahead with surgery, with cancellation meaning depriving someone from a cure. And so I think that Europe is better organized when it comes to the pre-op evaluation, because you have pre-op clinic and you have usually more time to prepare. Like even a week can make a difference. It's really hard to prepare someone who comes the day before for surgery and then shows up to the operating room the next day. And so there's a lot of judgment that is being used and a lot of discussion in terms of the risks and what to do in the post-op period.
Grazie. Sì, perché adesso abbiamo anche delle opzioni come per esempio le TAVI, le Mitra Clip che possono entrare nella decisione. E anche ovviamente volevo sapere se voi considerate per esempio nei pazienti coronariopatici l'utilizzo di per esempio il contropulsatore aortico, cioè di cose provenienti dalla cardio praticamente, cardiokir. Se è qualcosa che i pazienti che hanno una ottima performance polmonare con una scarsa performance cardiaca.
Allora,
proprio perché il rischio di progressione è importante, come dicevi tu prima.
questi casi ovviamente vengono fatti in centri che hanno cardiac, per cui è il cardiac anesthesiologist che si occupa, in aggiunta al fatto che hanno una terapia intensiva che può occuparsi del post-op course di questi pazienti rispetto ad essere fatti in un ospedale dove non hanno mai visto nessuno di questi devices. In generale, ovviamente, ok, sorry, io non riesco a parlare più in italiano.
In English is fine as well.
So, I don't think that anybody should be deprived of an operation because of a status that could be corrected by any sort of external device. But you have to keep in mind the potential complications related to the placement. For example, ECMO. You have someone that, like a mediastinal mass with significant cardiovascular compromise and respiratory compromise. You can put them on ECMO and get through the case. However, you need to keep in mind the fact that the patient will be anticoagulated. And so all the complications that come with that decision making that you have. Now, if the benefits overweigh the risks, at that point you go ahead and you plan on what to do intra and post for that. So for your patient with that device, it shouldn't go to a hospital where they don't have cardiac. Like in my place, it would never come because we're not equipped to go on pump, and our ICU is cancer ICU. So our patients are dying of cytokine release syndrome. We don't do cardiac. So it would go to Cornell, just to give you an example, or to Columbia or NYU.
Yes, I agree. Thank you. Okay, now we move to a different, a different question. The question is, do you think that transpulmonary thermodilution is as effective as the thermodilution for the management of stroke volume and cardiac output?
So
because
like
you say that you don't use thermodilution anymore.
So anything that relies on intrapulmonary pressure when you do thoracic, you need to keep in mind that you have iatrogenic changes of that from thoracotomy. But even when you do thoracoscopy, they insufflate. And so what you read, I mean, the absolute value may not be that accurate. You can decide, I'm going to use whatever you want to use to follow trends and use that to help my management. However, many more people use TEE even during thoracic for hemodynamic management, just because it's perceived less invasive and it gives you a lot more information in terms of like visualizing. It's true that you give up measuring directly pressures and you end up calculating parameters. And so I think that you can use anything that you're comfortable with for the purpose that you're using it, with the caveat that you need to keep in mind that with the chest open and the insufflation, the numbers that you read may not be the absolute numbers.
Thank you. Now we have a live question. Thank you for your presentation. In your hospital, EBUS is performed with the patient intubated or with laryngeal mask or sedation?
No, so thank you for this question. So in our place, we do the EBUS with general anesthesia, and we put a supraglottic device, with the reasoning that some of the stations that they are going to biopsy are above the carina. And so if you put an endotracheal tube, the tube physically is gonna cover the lymph nodes. And so you're gonna end up pulling it so much that the cuff may be sitting through the vocal cords. I personally like to use IV, so total TIVA, just because there's a lot of leak. And so if you use inhalational agents, everybody falls asleep and the patient may be awake. And those cases are outpatients. Either the thoracic surgeon in our institution do them or in their interventional pulmonologist. And I treat them like you're doing anesthesia for a colonoscopy. And so you want to provide amnesia, you want to provide stillness. They don't have any pain. They may wheeze at the end. And so if you want to give a cocktail of nebulizers, if you put a supraglottic device, the scope that they use for the EBUS is fairly large. And so you may end up having some vocal cord edema. So I like to add some racemic epic to the cocktail by the time that they recover. By the time that you transport them to the recovery room, they are not bronchospastic, they stop coughing, and they are not hoarse.
Okay. Thank you. What is the training of American resident for bronchoscopy? Do you have a specific program? Do you require specific skills as well?
So it depends who the residents are. So for our residents, it's in the OR. We do simulation. So we have mannequins, we do workshops. So they have the ability of trying, in vitro, and then they come to the operating room. So they have to have a certain amount of cases done by the end of their residency. I don't know exactly how many specifically in terms of numbers they have to do. And so that's, if the question is, do you have a structured rotation where all you do is fiber optic bronchoscopy? This is the pulmonologist. So in the operating room for thoracic, we have a bronchoscope in every room. And so we do a lot of fiber optic intubation as part of the process, so that you can learn how to put a double lumen tube with a fiber optic or a single lumen tube. When I was a resident, all my cervical mediastenoscopy, I used to intubate them with the fiber optic just to get practice. But now we don't do cervical mediastenoscopies anymore. And so the amount of fiber optic intubation, at least for that rotation, may have gone down.
Okay. You perform a very interesting trial on serratus. Did you use a one shot or did you put a catheter for the analgesia?
No, we did 2 injections at T4 and T8, single injection. We mixed bupivacaine 0.25 with dexamethasone and clonidine. And we did 2 injections on the mid-axillary line prior to waking up.
And which local anesthetics?
BUP.
BUP, okay.
Hydrochloride.
Or not?
No, regular.
Regular. And any complications? Very safe block.
It's a very safe block. There's no vasculature in the area, so the chance of giving hematomas is very low. And once you hit the rib, you're doing it under vision. You can see like a nice pocket opening. So we didn't have any complication related to the needling process.
Another question: do you think that the anesthesiologist can affect the surgical approach, can change the surgical approach due to the comorbidities or things like that?
Yes. Why not?
Okay. So, do you think it's safer, the robotics, VATS, or open
All right. So I think that we are consultants, right? So there's a good definition, at least that's what I used to be told when I was a resident. And that's the whole point of graduating. You graduate to be a consultant, so you're an expert in anesthesia. And so your expertise should be used to provide a plan that you discuss with the surgeon. The patient is in the middle. There's not a wall, there's a curtain. And sometimes the curtain is not even there at the beginning of the case. And so you make a plan. And so can anesthesia change the approach? Yes. So I think that in terms of the surgical technique, the hospital course is much shorter for minimally invasive. And so we're not going back doing thoracotomies. I mean, the evolution of surgery is moving towards more and more minimally invasive cases. And so I think that everybody should get at least a chance of trying with thoracoscopy. But I think that where the discussion helps and our contribution helps is in case plan A fails, how do we go to plan B without, having problems? And so if there's any issues in terms of opening, or personally, I feel that yes, peripheral nerve blocks are really good tools to have in your tool bucket, but we're not there yet for the peripheral nerve blocks to replace completely an epidural. So if you have someone who's a pulmonary cripple with bad PFTs, and my cutoff is less than 40% predicted, FEV1 and the LCO, you know that those patients are not doing well. They're not going to be coughing. If they're splinting, they're going to become hypercapnic and hypoxemic, and they're going to spiral down to get reintubated. So you really need a good analgesic option that is long lasting. Those patients, independently of the surgical technique, I think that they should have an epidural. And it's much easier to put an epidural pre-op than post-op so that you can use it during the case. I mean, you can do a thoracic case on the regional with some sedation and go through it, right? We've done LOS or flap under sedation and regional. So what you're doing with your general is just providing stillness and amnesia. Your main anesthetic is your local. And so that's where we make a difference. So the discussion pre-op in terms of having a plan, and there may, the need to go back and forth multiple times in this exercise. But once we have a plan, at that point, you execute it.
Okay, thank you. Two live questions. Do you have a rescue strategy when in case of hypoxia after the start of one lung ventilation?
So this is a very nice question that brings all of us back to the days of physiology. So as you remember, and there are like studies done in the sheep, you have a biphasic curve for the hypoxemia when you go on one lung, right? You first have the first 40 minutes, then you set, and then in 2 hours, everything goes well. If you're doing an anatomical resection, they clamp the pulmonary artery, they shift, ventilate. I mean, the perfusion goes down to the lung that you're ventilating, you have better matching, and so you have less problems. So for the rescue, nowadays is rare that we have as much hypoxemia as back in the days because, we have the fiber optics. So the first thing before you start the whole exercise, before they put the drapes up, you want to recheck that all your equipment is well positioned. And so before clamping, you go back with the fiber optic, you make sure that the double lumen tube hasn't moved up or down, usually down, so that you're wedged in one of the lobes. And then you go on one lung. Now, there's a lot of recommendation to start with 100% so that you expedite lung collapse. And so that's going to buy you some time, and then you decrease your FiO2 once the lung that you are operating on is collapsed to less than 100%. Now, when you have hypoxemia, you do the usual maneuver, right? You just make sure that the tube hasn't moved, you don't have secretion, you're not bronchospastic. So these are the 3 basic things. So check with the fiber optic, give recruitment, give bronchodilators, and then it depends. So when you think about saturation, there's nowhere that says that 90% is the way to go. There was a study where they took healthy subjects and they had them climb the Mount Everest, and they did serial ABGs as they were climbing after they acclimated. And the youngest guy who was able to climb at the top, his saturation was very low, but they became all polycythemic. And so the point that this paper was making is that it's the carrying capacity that matters, not just like the number. So if you are anemic, 90% is different than if your hemoglobin is higher. And so that's something to keep in mind. There are several strategies to manage hypoxemia. So first you start changing the setting of the lung that you're ventilating. The book tells you that you can put CPAP on the lung that is collapsed. It's the very, very last resource, because if you're doing robotic cases, once the lung starts inflating, it gets caught in the instruments and you start tearing it. And you've seen a tear lung. It starts bleeding and it's really hard to fix unless you start wedging. And so these are kind of like the, dirty way of dealing with hypoxemia. But eventually time helps and things get better.
Yeah. When you recruit the operating lung at the end of the surgery, do you use the ventilator and adjust the setting, or you use the bag with an APL valve?
The ventilator.
Okay.
And I make sure that it's not 100%. If someone comes in on room air, when the lung is expanded, the FiO2 should be the lowest possible, because there's data that that's when you cause injury in terms of like pro-inflammatory mediators.
Okay. Thank you. I have a curiosity. How do you treat the ipsilateral shoulder pain?
So our
Because
surgeon,
sometimes it's a
no, we
very,
don't do
very
regional, so we
difficult
don't
to
block the
manage
diaphragm.
in the clinical practice. This is
So
my
it's
curiosity.
No, it's not with blocks. And
Okay.
so I think that the multimodal helps a lot. So if you can combine NSAIDs and acetaminophen, it's really helpful. And then we give them packs. Some people I know do blocks.
Yeah, we perform a block, to be honest.
So
With a very, very low concentration of local anesthesia. We with short acting also anesthetics, because we know that it's sometimes very bad that the patient is not able to move the shoulder. And so just to, because sometimes it's very hard to manage also with the
yes.
okay, we agree. I think that there are no other questions, and I think that Giovanni, if you like, you can.
Faccio vedere semplicemente cosa abbiamo fatto finora adesso: lezione del prof Gattinoni, lezione del prof Mistraletti, lezione della prof.
No, solo un secondo, Giovanni, c'è credo il professor Bazzi che ha una mano alzata, vedo adesso.
Sì, ma non era così urgente, era solo che, visto che ho introdotto Alessia, volevo chiudere la presentazione Alessia prima di parlare del futuro, dicendo che mi piacerebbe pensare che tutto quello che ha imparato Alessia sia stato merito nostro, come
Assolutamente.
coefficienti. Non è vero, però mi piace pensarlo. Credo e spero invece, come messaggio che un po' alla scuola, che quello che ha imparato come curiosità, come metodo, e tornando all'introduzione di Roberto, sia stato qualcosa che si è portato negli Stati Uniti, Alessia, e che credo che sia stato il vero motore per arrivare a questi risultati. Per cui mi piace sempre chiudere il messaggio come scuola di vedere il modello Alessia come un modello da seguire, e credo che quello che è la volontà tutti noi di dare alle scuole, al di là della competenza, sia uno spirito e un metodo che poi ognuno sviluppa. Alessia è andata per fare una cosa ed è diventata un genio in un'altra. Però credo che forse il metodo sia quello, e quindi mi piaceva chiudere in questa cosa perché credo sia stata un bellissimo seminario. Ringrazio molto ancora Alessia e non volevo intervenire su Giovanni, ma era solo perché volevo chiudere. Grazie ancora e ti lascio chiudere come sarebbe stato giusto. Grazie Alessia.
So, concludo io. Grazie mille per avermi invitato, è stato un onore. E adesso Luca l'ha messa sullo scherzo, ma io sono stata forgiata al Policlinico. Quando sono arrivata ero una studente di medicina che aveva bisogno di un argomento per fare la tesi, e ho lavorato con Paolo Pelosi, di cui sono ancora traumatizzata, ma essendo l'uomo un genio, mi ha dato le basi con Gattinoni, Brazzi e tutti quelli che erano nella mia classe, di sviluppare un metodo di pensiero. È semplice, soprattutto nel 2024 con tutto AI e chat, perdere la capacità di pensare e guardare e bigiare. Il professore diceva sempre perché. Allora, qualsiasi cosa che uno diceva, lui chiedeva perché. e il perché è rimasto nella testa, per cui quando io faccio l'anestesia e chiedo ai miei specializzandi perché vuoi fare questo, mi devi dare una risposta. Per cui è una roba che è stata insegnata nel 1996 e 20 anni a questa parte è ancora lì. Quindi le opportunità vengono, sta alla persona prenderle e a volte l'opportunità capita una volta sola, per cui quando il prof mi ha dato la possibilità di venire negli Stati Uniti io l'ho presa e ne sono molto grata perché guarda te cos'è successo. Il mio esperimento non ha funzionato, è stato un disastro. Allucinante, ho ammazzato tanti di quei ratti che ho mandato in deficit in laboratorio. Però eventualmente qualcosa è venuto fuori e poi è venuto fuori di più e poi ho deciso che volevo fare l'anestesista. Non ho osato dirlo al professore perché avevo paura che mi urlasse dietro e davanti, ma alla fin fine, cioè, le cose cambiano e è un peccato che se ne sia andato perché viene a mancare un genio. E, e- però direi che ha avuto talmente tanti di quegli studenti che un pezzo del genio si è trasferito non per via genetica, ma per osmosi o per via traumatica perché pigliava steccate di sigarette se non capivi. Um, nonostante le buone memorie, ha avuto un sacco di scienza che ha trasfuso in tutti i suoi specializzandi e direi che il compito degli specializzandi e dei suoi alunni è di trasfonderlo alle nuove generazioni, per cui prendete le opportunità. E con questo ringrazio e non ho pianto.
Ottimo. Io volevo soltanto ricordare il prossimo seminario, che è il 9 gennaio dell'anno prossimo. Claudio Ronco. Se i giovanissimi non l'hanno sentito, possono anche andare a leggere su Wikipedia, quindi è uno dei pochi scienziati che trovate anche su Wikipedia. Ci parla dell'evoluzione della CRRT in terapia intensiva. Questi sono i 3 account Twitter dei nostri reparti e questo è il canale YouTube dove trovate le presentazioni pregresse e dove metteremo anche questa registrazione.
Bene,
Direi che
grazie.
abbiamo davvero concluso.
Grazie Giovanni, grazie mille davvero Alessia, è stato
Grazie ancora per avermi invitato.
un webinar stupendo che ci ricorda come siamo medici del perioperatorio e questo è molto importante. Ringrazio di nuovo tutti chi ha partecipato e chi ascolterà in futuro sul nostro canale e quindi l'appuntamento è al 9 di gennaio. Grazie a tutti.
Grazie ancora e buona giornata.
Ciao a
Buone
tutti, ciao
feste,
Alessia.
ci
Buone
sono anche le
feste.
feste, per cui
Sì,
buon Natale a tutti e buone feste. Ciao.
Buone
ciao.
feste.